And hello and welcome to the 196th episode of the 988 Crisis Jam. I'm Dr. Brian Sims. I am one of the senior medical advisors with the National Association of State Mental Health Program Directors, and I am thrilled to be part of the 196th episode. I can't believe that so many episodes have occurred, but we are so thankful for all of you joining us. And we're going to be doing this particular episode centering around behavioral health workforce development strategies. And what you'll see in this jam today is that it is heavy on the NASPID side because we have a number of our NASPID colleagues that are going to be represented in this particular crisis jam. We will be favored in our regular session with the behavioral health workforce development strategies as delivered by our own Wendy Morris and our own Ted Lutterman. So we're looking ahead that this is going to be a wonderful crisis jam, and we just welcome you all to it. Okay, next slide, please. Just a reminder to everyone, as you're calling in from all over the country, just a reminder that we are going through a time change, and this is going to occur this weekend. So just a heads up that it should occur 2 o'clock in the morning or otherwise, but depending on what time zone you're in, since the crisis jam is built on Eastern time, please make your 1 hour adjustments in order to be able to set it so that you don't miss out on any future episodes of the crisis jam. So just a kind of reminder as we go into this weekend. And next slide. Also, to go to talk.crisisnow.com. This is your source of tremendous amounts of information, folks. Whether or not you are already a member, and what we're hoping is that many of you will go to this page at talk.crisisnow.com and sign up if you aren't already signed up for it. Just a reminder that when you sign up for talk.crisisnow.com, you will be asked for just a bit of information that will help you to be able to be registered. And it's important that you get registered and that you use your own Zoom as a registration process so that we can send you unique links every week so that you don't miss a single episode. It's also a reminder that within this site, there are a ton of information sources. All of our recorded elements of the crisis jams of the past are available for you. You can go back and touch on any of them. There are a number of recent articles and related information. So it is chock full of information that can be extremely helpful and very useful for anyone. Let's go to the next slide, please. Now, at this point, wanted to find out if we happen to have Julie Grummett. Dr. Grummett, I don't know if you're available. If you are, would you come off of mute and let's see? Oh, I see you. I was wondering, Dr. Grummett, if you would, and I apologize if I'm mispronouncing your last name.
Nope, you got it.
Did I get it?
You got it. Grummett.
That'll be a first, boy, I tell you.
No, it's a telemarketer when they pronounce it Grumet.
Grumet? Okay. Well, I just welcome to the Crisis Jam #1. And I just wanted, if you could just take a couple of minutes to talk about this very, very, very important topic here.
Yeah, thank you for having me. We created this video. It is about an hour long. I saw that somebody put the link in the chat, so thank you. It is a video we created and we recently released where we interviewed parents whose child made a suicide attempt, and we interviewed experts and put together this resource for healthcare systems, community partners, schools, faith communities, really anybody to share with a parent after their child has made a suicide attempt. The essence behind it was, what are the things that we want parents to know, and what might they not know? So part of it is empathizing, right? These are parents who have been there, who say, this is how I felt. You might be feeling angry, upset, scared, terrified, mad, all anxious. All of those things are valid. And so we interviewed parents to talk about that, but then we also went very much into, what do you need to know? What is a safety plan? What are the best practices? How do you find a therapist? And then we also went into, what happens, you're bringing your child home if your child was hospitalized. What happens when you have to punish your child? They do something that upsets you and you want to punish them and they threaten that they're going to kill themselves. How do you talk to the school? How do you talk to their siblings or other family members about their suicide attempt and about this hospitalization? So we really tried to do the array of what are the feelings the families might be grappling with. What are specific resources about therapy, therapists, and what should you be expecting in terms of evidence-based best practices? And then what are those questions that always emerge? It was designed to be as if you're sitting at a coffee shop talking to a friend who's been through this already and just having all of those conversations about, tell me everything I should know or that you wish somebody had told you. And we did that through interviewing parents and interviewing experts so that it's that blend of both the feelings as well as what does the evidence base say. We are disseminating it now, so that's why I have the chance to share it with you all. I hope you'll disseminate it, but ideally, it would get disseminated in a standardized way, printed at the bottom of a discharge summary, distributed through pediatricians in schools in a standardized practice anytime somebody talks about suicide. So let me know if you want to work with us to disseminate it. That's our plan over the next year, is to really figure out how to ensure that anybody who's going through this with their child has access to this resource. So thank you for letting me share it with you. Love to hear how you use it and let me know. I'll drop my email in the chat as well and let me know if you want to work together.
Julie, thank you so much. You may not be able to actually see what's in the chat box, but a lot of thanks to you for placing the resource in. I think what you've done is you've opened a lot of perspectives of individuals who had it in the back of their head. What do I do next? How do I handle this? And here you're offering this resource. So it is in the chat box, and we do encourage you folks to link up to it. Julie is given permission to use it in whatever format, correct? Okay. Well, then what that says to us is that you now have an extra tool for your toolkit. So thank you so much, Julie, for that. And that's going to be very helpful going down the line. And thanks for the email as well. So folks, you can continue to also put into the chat box any comments or questions or otherwise, even after Julie has left us, and we'll be sure to get questions over to you. Okay. But thank you again, Julie. Appreciate it. All righty, going to the next item, we want to talk about some lessons learned from SAMHSA's first LGBTQ plus Behavioral Health Summit. And this is something where, if you want to reference it, we're going to put a link in the chat box just for informational purposes so that you're able to gather up the ongoing work and the attention being paid to the behavioral health needs of our specialized populations. So please take time out to check this particular element from SAMHSA out. And next slide, please. And we have now made it to our crisis trivia hot seat. Now, while we don't have anyone identified, I'm going to try something here. I don't know if it's going to actually work, but I attended a session in Westminster, Colorado, just a couple of days ago. And I was speaking to a number of folks there, and one of them said that they were going to sign up for the Talk Crisis Now and get on to the Crisis Jam and would be on today, and was very interested in potentially being on the hot seat. And what I'd like to do is maybe open it up to see if anyone might be interested in participating in the hot seat. Otherwise, we'll just do it as a audience participation. So we'll just give it a moment to see if anybody would like to come off of mute and be a participant. All righty. No one's stepping up, so I'm just going to go ahead and use this as an audience participation time. For those that were thinking about it, you have lost that window where you could have gotten a nice t-shirt or a hat or otherwise, but let's just move on. Today's trivia hot seat question really talks about behavioral health workforce, and this is going to be what we're going to be discussing throughout this particular crisis jam. And it says behavioral health workers face a high risk of burnout due to the challenging nature of their jobs. Now, burnout contributes to high turnover and exacerbates the issue. So our question for today, according to recent workforce studies, what is the most frequently cited reason for behavioral health professional burnout? You have your choices in front of you. Is it A, administrative burden, B, compassion fatigue, C, large caseloads, or D, insufficient compensation? So we'll wait and allow the audience, please, if you would answer the poll. We encourage each and every one of you to answer so we can have a good overview of how the audience has been. And you guys have been phenomenal in the past. So I have all the faith in the world that we're going to bring this one through. So we'll give it a moment and see where we are. Okay, we should be getting some results momentarily, and what we have is across the board. The best way to describe it would be pretty much across the board with a slight edge on compassion fatigue. Now, I'll be first to tell you that that was the one I chose. So, a learning curve, but the actual answer to this is administrative burden. Because according to recent workforce studies, what they have shown is that paperwork and administrative tasks tend to be the leading cause of burnout, taking upwards of 30 to 40% of their time that could be spent on direct care. So a learning curve for me, and this is why I'm so thrilled to be able to go to our speakers for today. So today we're going to have a discussion on behavioral health workforce development strategies for the State Mental Health Authority. And we're going to be favored by our own Wendy Morris, who's our Senior Behavioral Health Advisor with NASPIT, and she will be followed by Ted Lutterman, who is the Senior Director of Government and Commercial Research at the NASPIT Research Institute. So Wendy, without further ado, take it away.
All right. Thank you so much, Brian, and delighted to be here today and talk a little bit about behavioral health development, workforce development strategies. Next slide. I am going to take just a minute to kind of set the stage, because this is kind of aimed at state mental health authorities. So your state departments for mental health, everything is transferable if you don't work directly with those agencies. But at the state level, we have a lot of common challenges that are different from the private sector. One is that states have a personnel cabinet or some other kind of government structure that there are statutes that have to be followed, regulations that have to be followed. This can make it very difficult to be innovative, very difficult to hire people because it's all very structured and there's not a lot of leniency or ability to kind of stray from that. And even if we are contracting with a entity for our staffing or for services altogether, there's procurement processes, contracting processes that are all very difficult. And then just the natural turnover in leadership. There's a federal level turnover in leadership, governors turnover, cabinet leaders turnover. And even for commissioners and directors for behavioral health, we know that the average lifespan in those roles is about 18 months to 2 years. That's the national average. Of course, there are a lot of variances between states that can make workforce development more difficult in some states than others. The population density and topography can make it very difficult to find staff in certain areas or for staff to get certain places to do things like outreach or mobile crisis. The existing system of care, how much development is needed, what's the breadth of the workforce shortage that they're experiencing? Is it across all disciplines and all work areas, or is it limited? What's the political structure? Is it one that supports behavioral health services and the development of those workforce? What's the available funding? Is it a Medicaid expansion state so that there's perhaps better or more broad reimbursement for services? Is there funding outside of that for innovation to try something new? Next slide. So here at NASPID, one of the big things we do is try to create opportunities for sharing and replication. And so this Behavioral Health Workforce Resource Guide is really a compilation of stories and examples from states and territories of what they're doing to build workforce. So we interface with our members quite a bit. And this is lots of things that they've been telling, what's working, what they're trying, that they're not sure is going to work yet. And this QR code will give you the full document. This went up on our website in April of 2023. We just started the process to update it, and we'll get the next version out hopefully in the summer of 2025. But it has some cross-sector strategies. Always we want to decrease the demand for acute care services by making sure we focus on prevention, early identification, and intervention. We want to be sure that there's adequate reimbursement with parity and having a business model that supports the implementation of evidence-based practices, and to pay attention to what statutes, regulations, policies need to be modified to accomplish our goals. The guide has a framework that we adopted with permission from the National Conference of State Legislators. The thinking being, let's develop a common language so we all are talking about the same thing. So one is understanding needs. So this goes beyond vacancy rates, looking at health indicators, talking to peers and family members where they think we can get the biggest bang for our buck. Where do we need to focus those initiatives? Increasing supply. How do we get more people interested in doing this work? Expanding reach. How do we take our current workforce and help to reach more people, right? By decreasing that administrative burden we just heard about, using technology so that we can reach people without them having to come to the office. Addressing distribution to make sure we're getting services to underserved communities. And then how do we keep the workforce that we already have? Next slide. So these are some of the trends. Again, we put the resource guide out in April of 23. So these were things we were hearing in 2022. So I'll give you these and then I'll go over some things we've learned since then. So a big focus states have had is on developing new entry-level programs and incentives. So some states have had websites to attract more people. Doing outreach to high schools or to community groups. Working hard to eliminate barriers to entering the field with scholarship programs, mentorships, paid apprenticeships. Lots of expansion in how we're using peers across the continuum. A lot of that is in the crisis services as well. And we've heard some of that on Crisis Jam before, but also new roles for liaisons and navigators who may be interfaced with criminal justice or emergency departments or other key stakeholders. The use of technology is really important. A great program in Oklahoma where they're using iPads for people discharged from state hospitals and giving them to law enforcement to use when they respond to crisis to get people in touch with mental health professionals. It's always, the caveat there is always make sure that our staff know how to use the technology as well as the people that we serve. Improvement in wages and benefits is something several states have been able to accomplish. Creating a supportive work environment, which I'll talk more about in just a minute. And then always a focus on equity and diversity to make sure that our workforce mirrors the community we're serving. And it's also a great tool for recruitment. Next slide. So one thing that states are really starting to pay attention to is reimagining their treatment team. And one way to do that is to expand the pool of candidates by updating the human resource policies, creating new roles. Again, where else can peer support plug in and be of benefit to the people we serve and to enhance our treatment teams? How can we use navigators and liaisons? Bringing in interns, folks who are still in school and still learning, but make those paid programs, apprenticeships, mentors. We lose so many people early on because they find the job is maybe not what they thought it was, or they don't have the help they need to really master it. Administrative assistance, again, people to help with that administrative burden. Revising job descriptions has been another big focus. Background checks comes up a lot, especially as we look at the forensic space and we look at specifically at forensic peer support specialists. And can we switch up what we really need to be focusing on for background checks? Educational requirements. There's jobs that require just any bachelor's degree or a high school diploma. And we need to think about what skills we really need. Is it literacy? Is it other specific skills? And do those degrees, for instance, high school diploma doesn't necessarily mean a person is going to be able to to read and understand all of your forms or the things that you need them to do. So are there other ways we can check for those skills that we need other than educational requirements? Are there opportunities for supported employment? Folks who have supported employment for mental health, substance use, intellectual developmental disabilities, brain injury, again, expanding that pool. And then assuring that our workplace accommodates for people who have disabilities. What our environment of care, can they get in the door to work there? Or do we have a barrier right there that prevents people from even applying for our jobs? Does the workflow have the accommodations necessary for all people to be able to serve in those roles? And do we have communication that works for them? Next slide. Technology first, kind of a concept that comes again from the intellectual developmentally disabled community, where there's some states, I think Ohio and 23 other states, have laws that require that folks think about technology before they add staff. And that's so that people can live as independently as possible. But again, this concept is transferable to the work we do. A lot of common technology, telehealth, remote work, hybrid work, flexible hours, but lots of other things to do with technology. iPads is a good example. I talked for a minute about what they're doing in Oklahoma, but also just giving iPads to folks so that they can stay in better contact with family and their other support systems or their treatment team. Folks who maybe don't want to do necessarily a lot of one-to-one counseling or group therapy, there might be opportunity for individualized learning. Technology can help us with adaptive communication, translating things in plain language, using videos. They're great for folks who maybe don't rely on the spoken word, and then interactive ways to play, almost adult game, some games where you can learn that way. They're also good for helping people to practice relaxation techniques or to journal. So lots of ways to help. Technology for interpreter services. Again, people who don't rely on spoken word, who need to use communication devices. Lots of technology emerging to decrease administrative burden. They can do record reviews. They can do trend analysis. Also, a lot of technology emerging to enhance onboarding, staff training, and ongoing education, really learning to use artificial intelligence as a training tool. Again, a lot of people, we will lose a lot of people between the time that we offer a job and the time we bring them on, or during those first couple of weeks when they don't feel like they're getting the training they need. Next slide. So we talk a lot about trauma-informed care, specifically making sure that our environments of care for the people we serve are trauma-informed. But what about our staff? Is the work culture trauma-informed? Do your staff have voice and choice? Do they feel empowered, respected, supported, appreciated? And how do you know? How do we keep folks engaged in the workforce? Do your staff have skills in conflict resolution? And that's not just about, interacting with patients and having some sort of crisis intervention, but before it gets to a crisis, do people have the basic skills they need to resolve conflict with their coworkers or with other people in the community? And then this concept of attraction and engagement versus recruitment and retention. Dr. Sims, our host today, and I had the opportunity to attend a conference a couple of weeks ago, and the keynote speaker, Lou Raja, gave this really wonderful speech about why it's important to think about attracting rather than recruiting, which is kind of what you do in the armed services. And you're kind of talking people into coming. You got to reach out a lot to find people to bring into your organization. Attraction is kind of being that water hole in the desert. Everybody wants to go to it. Everybody migrates to it. Everybody looks for it. So how do you become that employer that's attracting employees? Same thing with engagement versus retention. Do we want to be retained, detained? Right? It doesn't have a great context. Rather, we want to be engaged. We want to feel like we're part of a team, that we're doing meaningful work, productive work, and that we enjoy going to our jobs. Next slide. So cross-sector partnerships are super important. We want to work with other people. So who do we usually work with and who else needs to be at the table, right? So we can create synergy, we can decrease duplicative effort. I've been involved in a couple projects recently where we're bringing together people from behavioral health and child welfare and juvenile justice and other places, and they find that some of them they're doing the same thing. So how can we decrease that duplication? If you can engage a workforce development expert, this is very different than human resources. Human resources are concerned about the organization first and foremost, right? What's our hiring process? What do we do? What are the rules for discipline, for firing people? What do we need to have in their personnel file for the accrediting bodies? Whereas workforce development is more about innovation. It's about strategic planning, about having goals. And they can help you do some of those things like engaging with other partners or creating a trauma-informed workplace. Higher education is another really important partner. We can work with them to develop career paths using stacked credentials, college credit. They can also help with program evaluation and satisfaction surveys. Next slide. This is just a really, there's a QR code so you can see the document that's way too small for you to read. This is a tip sheet that was developed by the Kentucky Department of Behavioral Health as part of their TTI Transformation Transfer Initiative project through SAMHSA that's funded by, it's at NASHBID and funded by SAMHSA. And this is just how can we put everything in place we need to be innovative where we are. And I won't go through them, but again, you can get the tip sheet. Next slide. I did want to, I think we skipped, okay, we missed a slide. Oh, there we go. Thank you. I did just want to make a little plug for this other document. So in addition to our workforce guide and all the TTI projects that we're doing, this is another example of work NASHBID's doing on workforce, partnered with Vibrant to talk about workforce challenges and barriers specific to crisis lifeline centers. And so it's another workforce, and there's a link there to get the report, and hopefully somebody can put it in the chat as well. Next slide. So I just also want to just make a plug for data. Data really matters. How do we know that we're having an impact if we're not measuring data? How do we quantify savings, right, to criminal justice, to the behavioral health system, to other stakeholders? How do we know that we're mitigating risk or providing for better patient outcomes? And are we aggregating the data we need that's important for our funders, such as Congress? And so kind of planting that seed about data, I do want to now hand it over to my colleague, Ted Lutterman from NRI, the NASHBID Research Institute, which is a separate organization, but an equally valuable resource for everyone who works in behavioral health. Ted?
Thank you, Wendy. If you go to the next slide, just if people aren't familiar with us, the NASHBID Research Institute, we were spun off from NASHBID 30 some years ago to be an independent research data collection arm working closely with NASHBID. Our board of directors are primarily mental health commissioners, but also includes some other significant representatives, members from the National Council, from the State Medicaid Directors Association, from the Council of State Governments, etc. But again, our focus is really to try and work closely with NASHBID and with states to help provide answers to their questions with data. And so this sort of lists some of the focus areas. We do a whole lot on performance measurement, documenting just sort of how states are organized, structured, what they're responsible for. We're doing several things around forensics, criminal justice interface. How do we keep people out of the criminal justice system and into services? First episode, psychosis. And then in particular, we do these state profiles that work with states to describe the major organizational structure, policies, services in each state. And there's a set of reports on our website that are available that the last couple of years, we've done a major focus on crisis services. So if you go to that QR code, for example, you'll see a report that describes where are states on the three major sort of components from the Crisis Now compendium, call centers, both 988 and other state call centers, mobile crisis teams for adults and for kids, crisis receiving programs, short-term crisis residential. And then there's some detailed reports that go through. There's one report on call centers, how many call centers are there in the state? How are they doing text and chat? How many are they receiving? How are they paying for them? Who runs them? What are some of their outcomes? And related to today's discussion, there's a section around workforce shortages in call centers. And then there are parallel reports that are available on mobile crisis services. Again, how many teams, how many programs does a state have? Are they available 24/7 statewide? What are the barriers to going statewide? And then a section on workforce for that. And similarly, one on crisis stabilization programs that again covers those same sort of topics. So those are available. And then in the next week or so, we'll be putting up a report on workforce shortages. And also we're working one on how states are financing crisis services. It'll be going up shortly. There are public reports on the website. States then have access to detailed data behind it where they could see individual state initiatives to try and address workforce, to take programs statewide if they're not yet statewide, to address 24/7, et cetera. So we want states and people to be aware of that information. If you go to the next slide, particularly around the workforce, and this slide is already out of date because we sent out last month a draft report for states to update. We'd hoped it was going to be done by this week, but because of the hurricane, we've had several states, particularly in the Southwest, ask for some extra time to make sure they could review it. Oklahoma should be red, and Rhode Island submitted information. They're also red, experiencing a shortage in their crisis workforce system. And so what we've got is basically we now have 44 states that responded, and 41 of them, or 42 now, have reported they do have shortages of workforce. But the report goes beyond that. If you go to the next slide, what we've been trying to look at is what states have shortages, but what are they trying to do to grow the behavioral health workforce? And what's interesting is states are doing a variety of initiatives that hit multiple levels. So high schools to try and encourage kids to consider a career in behavioral health, developing curriculum to help introduce kids at the high school level, like community colleges who might get an associate's degree and go to work in a behavioral health setting, college and graduate school programs. You can see these are the numbers of states that reported they have initiatives in each of these areas. Everything from mentorships to student-led initiatives, information about opportunities. So states are really trying to reach out and grow the workforce at multiple levels, from the professionals getting a college or graduate school degree to introducing high school kids. And again, on the website for states, there are some details, with states describing what actually are their print materials that they're developing, or what are they doing in terms of mentorships or stuff. If you go to the next slide, we also looked at some of these initiatives to try and increase the workforce, help keep them. So, providing teleworking, flexible scheduling has been identified by the majority of states as something that's really positive. States have done recruitment bonuses to try and hire people, focus on building a career pathway, especially for people like peer specialists. What is their career path so that they can grow in their position and not feel that they're locked in a dead-end job. Supporting for people getting their licensing and certification. That can cost a lot of money to become licensed or certified in some states, and states are trying to help facilitate people passing their licensing. A few states, well, actually almost half, are reporting even increasing salaries, focusing on recruiting of underserved groups, tuition reimbursement, et cetera. And again, we've got some details with what states are trying to do with those areas. The next slide, please. Just one last piece I wanted to highlight is we asked about workforce shortages, not just for the crisis system overall, but by the crisis setting, and what types of staff have the greatest shortages. So that one of the things that we see, for example, is, the types of staff that are short in call centers differs. In crisis call centers, states reported the major disciplines that had shortages were social workers, bilingual and multilingual staff, licensed behavioral health counselors. At mobile crisis teams, it was again MSW social workers, licensed counselors, peer specialists. But at the crisis stabilization programs and short-term crisis residential, it's a different type of staff. So psychiatrists were the highest shortage area, nurse practitioners, registered nurses, And then peer specialists were the sort of shortage areas that states were experiencing at those settings. And it was mobile crisis teams was the area of crisis services that states had the largest set of shortages. So with that, I'll turn it back to Wendy for this last slide.
Well, we just wanted to, again, hold this out as a resource. This is one of the Connected and Strong papers. It's a series of papers, again, funded by SAMHSA, and it's on their website, but the link is here. And this is one of the papers actually that NRI authored. So it's a very well done paper. I hope that you'll be able to look at it. It gives some good insights on barriers to recruitment, retention, and wellness among folks, such as low pay, and again, those bureaucratic requirements at the state level for job postings and so forth. And then it also will highlight some of these initiatives to grow and strengthen the workforce again, such as using peer support or champion employee wellnesses. So lots more detail, great document. And I think that's it for us. Brian?
Well, thank you. Thank you, Wendy. Thank you, Ted, for accomplishing that Herculean task of really taking a lot of information and putting it in such a concise framework so that you have a lot to absorb. We do want to remind people that there are a lot of really valuable links in the chat box that you want to go ahead and click on, because it contains a tremendous amount of material. But thank you, Wendy. Thank you, Ted, for all of what you just presented. I'm going to move over now to our roundtable discussion. I just want to call on Kristen Nayland, who's the Associate Director of Government Programs with the Nashville Research Institute. If you'll just say a few words on comments and whatever you'd like to add on to this discussion.
Sure. Thank you so much, Dr. Sims, and thanks again to Ted and Wendy for your great presentations and really discussing the value of data and the challenges that face the behavioral health crisis workforce. So at NRI, in addition to the state profiles that Ted has discussed, we've been fortunate to work on a series of other projects with NASHPD for SAMHSA, as well as states and providers and other entities to help understand the workforce shortages and challenges, and help understand if growth strategies are effective. Because you can have great ideas and implement them, but if you don't know they're working, they're never going to get funded again. And, what's the point? But these efforts can really help us to identify the barriers we may not necessarily expect, like the administrative burden that we found earlier in the hot seat question. Data can also be helpful to ensure that the workplace is representative of the individuals that are being served, and to help states and others evaluate data related to initiatives for effectiveness in recruitment and retention, like the examples that Wendy discussed earlier on. We've also done some data collection to help states and providers understand where gaps are in their systems, so that cases can be made for additional funding and resources. Most recently, we completed a report for SAMHSA's 2023 Transformation Transfer Initiative, or TTI, with NASHPD, looking at the effectiveness of 50 state awardees. Half of these awards were focused on workforce development initiatives, and half of those were also focused on the crisis workforce specifically. Many of the awardees focused on expanding the role of peer professionals, including developing toolkits for providers on their effective use and how to most effectively integrate peer professionals into mobile crisis teams. Other programs are focused on developing training academies for all crisis staff, involving staff in shared decision-making to improve crisis response and better prepare them to respond to individuals in crisis. An example kind of combining both of those strategies is from one state in the South, where they're training young adult peer supporters between the ages of 18 and 21 to respond to youth and young adults in crisis. And they found that training these youth gave them the confidence to respond in stressful situations to help someone during their worst day. The 2023 is not available yet, but the 2022 TTI report also has some interesting results related to workforce that I can put a link to in the chat. One other thing we recently worked on, NASHPD just published the 2022 technical assistance paper for Beyond Beds that I authored on telling the story, data, dashboards, and the mental health crisis continuum. A section of this paper identifies some specific measures that states are looking at to help understand the strengths and weaknesses in their behavioral health workforce. And I'll also stick a link to that in the chat if you're interested in checking it out. So thanks again for having me today. And I think I'd like to hand it over to Christy.
And I just want to echo your comments, Wendy and Ted, thank you so much for just really highlighting some of the workforce strategies that have been really successful in helping to support communities across the nation. So I think for me, one of my key reflections, Wendy, I think you said earlier, is that multifaceted approach that we need to take to really help support the workforce, and looking at creative strategies. And you mentioned about moving more upstream in preventive and early intervention strategies. So I think one of the key things I think of is we have smoke detectors all in our house, in our offices. That's preventive. It's to make sure that it reduces death by fire. So, and when that fire detector goes off, that's an early warning sign that we need to leave, we need to escape. So what can we do as a field, I think, to really look at some behavioral health tools to implement earlier and more universal wide for that preventive and early intervention strategies. And I really reflect back on 988. We've seen that shift, since 988's launch and the growth in the 988 numbers. And I think one of the things is that, 988 crisis counselors are, really helping 988 contacts. So, and the help seekers, and they're saving lives and reducing suicide rates. And how can we help support them? So, and really make this, as you said, a workplace that is supportive. And one of the things I think Wendy and Ted had touched on, it's the skill sets. Let's look at somebody's skill sets rather than their credentialing. So because for example, people with living experience and peer support specialists bring a wealth of information to the crisis workforce space. So, and I think that's, another unique way that communities and states are looking at creative strategies when they're reimagining, Wendy, as you said, their workforce teams. And also, I really loved that concept of, changing that perspective in the work environment. I think it was more of Wendy, you had said attract versus recruit. And one of the things that, I think we can do as a field, with the workplace, yes, we can make it an attractive workplace, but I think we can take those concepts and look broader. How can we make the behavioral health field attractive to young students? So, for me personally, I think one of the barriers is that inadequate reimbursement rate for the behavioral health workforce. And Wendy and Ted, y'all both kind of touched on parity a little bit, but again, how can we interlink with medical, so in behavioral health, because working together, we're only going to be stronger in what we do. So, and again, really having that reimbursement rate to reflect the dedicated work that behavioral health workforce does. So, and on that note, thank you again for the opportunity to present on the roundtable, and phenomenal presentation.
I will echo that it was an incredible presentation, but also would like to thank you, Christy, as well as Kristen, for that wonderful roundtable discussion. My takeaway, a lot had to do with what Wendy and Ted talked about earlier in terms of primary preventive strategy. So Christy, I really enjoyed listening to that part of how important it is, because we talk about primary prevention, but then when we look at our workforce, the workforce is really looking towards primary prevention because that can make their environment much more safe to work in. So I would just like to thank all of you for this wonderful presentation. It has just been so information giving. And again, for those of you who have been listening to it, please check the chat line, because there is such invaluable links that you'll see in the chat box that are available for your usage. So thank you all again. And we look forward to continuing our dialogue and finding out how this needle gets moved. So let's move now to our SAMHSA update. And we have Dr. John Palmieri with us today. And Dr. Palmieri.
Hey, Brian, how are you?
I am wonderful. Thank you.
Good to see you. Good to see everybody, and really excited about this NASHPD focused meeting. NASHPD has just tremendous partners in all of this work. So really happy that there's an opportunity for them to highlight some of the critical work that they're doing across the crisis space. And particularly with respect to workforce, very much appreciate the focus on that today, and supporting our workers and helping to create new pathways to new workers, which is clearly a SAMHSA priority as well. So just a couple of things I wanted to highlight today, mainly a few activities that are underway with the support of our Crisis Systems Response Training and Technical Assistance Center. The first thing that I wanted to highlight is an upcoming webinar, which is part of our Children, Youth, and Family series. So this is focused on designing and expanding crisis services for children, youth, families, caregivers within a systems of care framework. That webinar is November 14th, 2 p.m. Eastern Time. There is a link for registration on our TTAC webpage, and also very excited to report that we are now starting to get approval for continuing education contact hours for some of our offerings through our Training and Technical Assistance Center. This is something that has actually been kind of in the works for a while, and happy that we're actually able to do that on some of the products that we're putting out through our Training and Technical Assistance Center. The second thing is the applications are open for our Cohort 2 Policy Academy on crisis systems design. And this is for states, territories, and tribes to convene with us and a number of subject matter experts, very much focused on their own identified goals at the state, territory, tribal level, using systems engineering principles, and also getting input from a number of experts on topics ranging from workforce to financing to equity to data measurement to communications to support their particular goals in expanding and strengthening crisis care within their jurisdictions. Many of you probably remember that we had our first Policy Academy last year in Tucson. And so Cohort 2 will be in March in New Orleans. And so looking forward to those applications, which are due, I'm going to get the date right here, November 27th. And again, the application link is available through our Crisis Systems Response Training and Technical Assistance Center. And then the last thing I wanted to just lift up, which we have talked about before, but I wanted to give kind of a quick status update, is on our model behavioral health crisis definitions work, which many of you have been tracking over the past several months. There's been a lot of activity with convenings and listening sessions and subject matter expert input in the development of model crisis service definitions, intended again to provide more clarity and alignment for help seekers, for system designers, and also importantly for payers to have more of a shared understanding and a shared language in terms of how we're talking about these services. So that model definitions document is currently going through the remaining piece of internal HHS clearance. As we've mentioned before, it is tied to the updated version of the national guidelines. And so that document is as well going through the clearance process. The definitions document is a little bit ahead of the guidelines document at this point. And so they may end up coming out for public comment slightly staggered. We haven't quite decided how to do that necessarily, and it will depend a little bit on the timing of the clearance process. But the definitions document is almost ready for public comment. We've talked about posting this for public input and public comment. And so that will happen sometime in November. And we will obviously flag that on the Crisis Jam and then as well through our other mechanisms to make sure that there's broad amplification and awareness of the opportunity to provide comment and input on the model definitions related to the behavioral health crisis services along the three pillars that we've all sort of commonly used with respect to our original guidelines. So more to come on that. As I said, we expect to get those posted out for public comment within, well, it'll be in November. So I'm guessing hopefully within the next 2 to 3 weeks. And I think that's it for me, Brian.
Well, as always, thank you. And thanks SAMHSA for the incredible work that you guys are doing in all realms and helping all communities. It's a lot to absorb, but as we say, it's all positive. So it's good things to take time out to absorb. So thank you so much. And thank you, SAMHSA. I'm going to move now to the NASHPIT segment. And I want to preface this segment by playing this short video. So go right ahead, please.
I was a technical sergeant, E6.
I served in Vietnam in 1969.
I was a sergeant in the United States Army, paratrooper.
I am a U.S. Army veteran.
I was in the Marine Corps 2000, 2004.
I served in the Army National Guard for almost 17 years.
I served in the United States Air Force for 4 years. This is my crew that I used to load bombs with.
I was a baby in this one. My first deployment in a Humvee and dirty and dusty.
This was related to my daughter, Brenna. It was her birthday. I was in Afghanistan, and I had my friend take this at the chow hall.
I truly almost don't recognize that person. It was the most meaningful period of my life.
It's just because it's hard being out. It's like still probably the best time of our lives, you know? You can't get that anywhere else.
Have I ever asked for help myself?
It's always tough, right?
Yeah, that's a good question.
I can't say that I have. I mean,
I always feel like I can solve my own problems, but eventually, you just can't deal with it on your own.
I guess it's a part of the military too, right? Service before self.
It was drilled in, service before self.
There's something about the camaraderie of some of the people I know from Vietnam. There is something deeper, I think.
Most of us, we're not gonna admit that we need to help.
If you don't have someone to kind of help you guide those thoughts, it can be really bad.
And you start to question, maybe people would be better off without me, When you realize that you're not alone, once you take that first step, there's so much support.
We just have to take the action to go and get it.
Again, very moving. And I wanted to use the NASHPIT segment for just a moment to talk about a recent event that occurred with a group called Together with Veterans. And it was my honor to be a part of that group and speak with other veterans about what's really going on. And it was about raising awareness of the crisis around it. This summit was held in Colorado. We were talking about individuals such as Dennis Mohat, who's the vice president for behavioral health through WICHE. And those not familiar with WICHE, it's the Western Interstate Commission for Higher Education. And they've been doing tremendous work with the community providers of veteran services by using veterans. And those veterans would then be advising the councils with regards to what services are really needed in the communities and how they can more collectively collaborate with one another. So I was very moved with that and brought the information back because this is just the beginning of an effort to enhance collaboration between the veterans element as well as the behavioral health services, with reality checks in mind that many veterans are seeking behavioral health services rather than direct veteran services. So it's about empowering everyone with all the tools that they would need to be able to work with veterans and to actually, as Christy and many of the others have pointed out, using even the veterans themselves and a lived experience profile to try to help one another to really put an impact on the suicide rates that are occurring amongst these veterans. So it was my honor again to attend this, and I was just so thrilled with it, and I just wanted to bring that information back to each and every one of you. All right, if we go to the next segment, I'm going to call on Stephanie to come forward and talk about this universal screening measure risk. Go ahead.
Thanks, Dr. Sims. So I'm going to bring on Dr. Kelly Posner. She is the founder and director of the Columbia Lighthouse Project. Dr. Posner, you shared with me that the Columbia Protocol should be included as a vital sign to assess someone's health. Can you share what the protocol is and also why a universal screening tool for suicide risk is critical?
Yes, I'm really thrilled to be here. And, I work with all of you states and communities, and diving deeper is really important. So, global agencies have said for decades that the lack of a common data element was one of our major impediments to suicide prevention. Mike Hogan, who was a mental health director, who is the architect of Zero Suicide, said that the Columbia Protocol is the blood pressure cuff. And if we had more than one blood pressure cuff, you wouldn't know what your blood pressure means as well as you should, nor would your doctor, right? And so the important thing to know is that it's also critical across the continuum of care. So the Columbia is policy across all 50 states, across the continuum of care. And that is vitally important that we have a common language, across providers. When it first became the crisis assessment tool in Tennessee 15 years ago, they said it's so important that the school and the EMT and the hospital are doing the same thing. Fast forward to today in Connecticut. This is a great example. Every policeman has this little sticky pad with the QR code that connects to Connecticut Resource, and they tell this really compelling story. Fourth grader, mobile crisis confirms, gets to the hospital. That more timely care delivery was dependent upon that common method of detection, right? And that's so important. And you know what it's also doing? It's reducing the level of force in the state of Connecticut, because these police don't have to keep going back to these wellness checks that they didn't need to go to in the first place. Magellan showed that when EMTs do it, it increases voluntary hospitalization. That's what we want, right? But on the heels of what we're talking about, what you guys were talking about today, workforce prevention, it's also used for that. So states and communities are using it to kind of care and save the lives of our workforce. So for example, Department of Homeland Security has their own Columbia Protocol app. So if you're Secret Service or TSA, it connects to their employee assistance lines, saving the life of my agent. In the state of Virginia, for the Department of Corrections, they have their own app for workforce prevention and fitness for duty. So if you're a guard, it connects to their particular EAPs, and really, really important in terms of caring for our providers. And on that note, and so Cleveland Clinic has their own app too, et cetera. All of you communities can work with us to do that. But I want to talk about how we leverage technology and how it connects to what we need to do. Did you know that pretty much if you look at any state, 80% of kids, of adults, of veterans end their lives in their homes, right? So how do we get in every home, in every parent's pocket? And that's one of the most important things that we learn in terms of how we need to do this universally. You asked the question, like, why do we need a universal, screening? Why is that important? Many of you know that 50% of suicides see their primary care doctor the month before they die. We need to be asking like blood pressure, or we won't find the people suffering in silence. 2/3 of adolescents who show up to the emergency department who've tried to take their own lives are not there for psychiatric reasons. But the big point is, we have to have that concept beyond the doctor because many people never get to the doctor. So the Marines were the first ones to say that. There was an urgent memo out of the Pentagon. We must put the Columbia in all hands because people don't get to the doctor. Legal assistants, financial aid counselors, chaplains, spouses, do you know, it helped them lower suicide 22%. And that's what communities all over the globe are modeling. I just need to tell you a quick story. I was giving a talk for the state of Connecticut again, and this huge health system said, you know, we gave it to the janitors. And this clinician from the VA said, exactly right. I'll never forget that case where the only person that it spoke to was the janitor. And these important concepts are tied with legislation, policy, implementation, and what it's ending up doing is really, really driving better use of our vital resources. You know, one of the
excuse me, Kelly, I'm sorry to interrupt, but
yes,
I would love to continue to listen to this, but we are actually out of time. And I do want to thank you so much. And thank you, Stephanie, for bringing Kelly on. And I agree. I think this is something we want to look towards the end of giving more information on, please. So thank you both. I just want to quickly just relate that we have several very nice crisis jams coming up, partnership driving innovations coming up next week. And that'll be followed by California service evaluations and learnings in 2 weeks. Also want to bring to mind the debates that are going to be coming up on December 11th. And just to make you aware, put it on your calendar. So thank you, everyone, for joining us today on this week's Crisis Jam. And we look forward to coming to the next one. So good day, all.